We go on to our next speaker, Dr. Mathew Kurian, who is the medical superintendent, senior consultant and head of the cataract and refractive services from Chaitanya Hospital and Research Institute based at Kochi. And he is going to be talking on surgical management of subluxated lens in myopia. So on to you, Dr. Mathew.
Thank you very much for this opportunity. So I'll be talking about the subluxated cataracts or subluxated lenses. And this can be both the crystalline lens as well as the natural lens. And what we need to know is that the etiology can be multifactorial and pediatric individual. And in high myopia, the retinitis pigmentosa is one of the situations where you can have it in the adult onset with the progressive zonulopathy. In terms of clinical evaluation, we need to be checking a few things. One is the family history, look for trauma and other visual symptoms, and also look for syndromes that may be associated with it. In terms of ophthalmic evaluation, obviously, phacodonesis is the most important thing, and we need to see whether the zonules are present. And when you see this kind of a spikes over there, you can be assured that there are some zonules, but these may be stretched. When you see a very rounded lens edge, it means that there is absence of zonules. Flat would indicate that there is attachment at either end. And we need to assess whether there is additional capsular damage and whether there is any, what is the density of the nucleus itself, whether any other associated posterior synechiae, vitreous prolapse, etc. is present. Coexisting glaucoma, retina pathology is very critical, especially in a myopic situation where there could be a presence of the peripheral retinal changes, which could lead to, if missed, could lead to a retinal detachment. Supine examination is very important in these patients because we are looking to see whether there is any ACD irregularity or asymmetry which worsens when the patient is lying down. So the risks that are involved are the vitreous loss, post-dislocation, posterior dislocation, or IOL decentration, which can happen in the late stages also. And the intraoperative challenges include those of the anesthesia that we would do. The placement of the wound, rhexis needs to be centered on the bag. Hydrodissection is very critical because that is what is going to allow us to rotate a bag with rotate the lens in the bag in the situation of weak zonules. Nucleus disassembly must be perfectly executed. Choice of fluidics is critical because we don't want fluid to go posteriorly. And so viscoelastic, which will tamponade the area of the dialysis, is critical. The choice of lens and where to place it and methods of IOL stabilization are critical. The biometry concept has already been touched upon by previous speakers, so I will not go further into details on that, except to mention that we should make sure that we are getting it on the macula and not on some aspect of a posterior staphyloma, which would alter the outcome of the biometry. So in individuals with focal dialysis, we need to be able to identify this kind of a very early situation and to be able to prevent it from progressing further. Generalized zonular weakness, as in this case, is much more easy to identify because the whole bag is mobile and the folds, as we create the rhexis, is very prominent. Only thing is we need to be able to make sure that we are able to not lose the bag at this stage and are able to retain the bag throughout this procedure. So shifting to a microcapsular rhexis forceps at this stage is very good. We can use a crosswords technique when it becomes very difficult to dimple and break the anterior capsule. And here you can see that gross amount of loose zonules are present. In coloboma eyes, the area of the rexus which is near the coloboma is actually the weakest, and intraoperatively that can tend to give way. Okay, rexus runoff can be seen. Here we are just tamponading the area of the dialysis. Intumescent mature cataract in a child. 20 gauge needle is used to puncture the anterior capsule and aspirate the liquefied cortex to reduce the intralenticular pressure. And then a microcapsular rexus forceps is used to initiate the rexus. The loose capsule is phacoaspirated, and bimanually it can be removed. But then we complete the rexus only subsequently. Unfortunately, this rexus has run a little bit to the periphery. So placing a CTR, there is not enough overlap of the anterior rexus over there. And so it will tend to prolapse out. So in this case, a less than desirable outcome in that the lens was just placed in the bag. Intraoperative stabilization can be by capsular hooks or CTR, and these are of various sizes. And then this is a video to show why it is necessary. Here you can see the bag has come entirely into the port and the fragment is just floated up. Fortunately, nothing goes behind, and we are able to release the bag and create space there and complete the case without difficulty. So intraoperatively, we want to be able to do proper stabilization of the bag using hooks, and later stages we can use a CTR also. Gross dialysis noted over here. So we are creating space for the CTR, which is placed early over here because of the gross nature of the 360-degree laxity, and viscodissection creates the space, and then the lens, the CTR is guided into the crystalline lens space that is created by the visco using a microrexus forceps. And once that kind of a stabilization is achieved, the equatorial collapse is prevented, and the nucleus management steps can be executed with relatively less difficulty. So this is being speeded up in the interest of time. One thing we must remember is that we should not be having a centripetal force. We should be using tangential forces to prevent the worsening of the dialysis. Once everything is done, the lens can be placed in the bag. Sometimes in the initial stages, the laxity is not so obvious, but on placing the lens inside the bag, you can see that there is this ovalization of the rexus, and this is indicator of weak zonules, and some amount of lens bag stability can be achieved by placing a CTR late, and you can see the round rexus there. Long-term fixation options, capsule retention rings or segments. And here we want to move the segment which is pre-threaded with 90 proline now. Earlier it used to be 10 proline, but we know that it tends to give way. Under a scleral pocket, it is railroaded through, and the lens is attached. The segment is attached to the area of maximum weakness. In pediatric cataracts, we have to use microrexus forceps to be able to well control the
1 minute left.
Rexus of adequate size. Phacoaspiration is all that is required over here. And once the lens is in the bag, we are able to then dial the lens into the bag, and fixation again. Instead of using the Sioni, which is a fairly bulky one, we are using a capsular tension segment, again attached under a scleral pocket in the area of maximum zonular weakness. And to achieve 360-degree stabilization, capsular tension ring is placed in addition to the CTS. So technically, surgery can be lensectomy, vitrectomy with aphakic contact lenses or spectacles, iris fixated intraocular lenses, scleral sutured. But in myopes, we have to be careful about the suturing because of the thinner sclera. Implantation of in the bag is most desirable, and femtocataracts can help in giving a good rexus in the situation of weak zonules. The nature of zonular weakness, whether it is static, in which case we can use a CTR. If it is progressive, we need to use a suture. The type of cataract, if it is a very hard cataract, we need to plan for SICS or something like that. Otherwise, in a normal cataract, we can plan for phaco. And extent of zonular weakness, if it is a very small amount of zonular weakness, no CTR is required. In higher amounts, CTR plus suture, and in extremely 180 degrees plus, maybe SFIOL or ACIOL is desirable. Finally, the complications, lens-induced glaucoma can happen. Lens can come into the anterior chamber, especially if the lens is touching the cornea. Then there can be decompensation. Lens opacity can be mature or hypermature, and there can be lens-induced uveitis. There can be inadequate visual acuity, not correctable by refraction. There can be incomplete luxation of the lens, and in myopes, retinal detachment is always a problem. Thank you very much for this opportunity.
Thank you, Dr. Mathew. That was a wonderful array of videos for every possible complication or challenge to happen. Do you have any experience of using a large optic IOL in a high myope?
Yeah. In a few aniridia cases, we have used those kind of very large optics, but it's also got a peripheral area of artificial iris to prevent photophobia. Significant challenge that I faced in pediatric subluxations was, you want to create a posterior opening in a younger child, posterior primary capsular rexus, and then for the subluxation, you need to place a CTR, and the combination of doing a CTR plus IOL in the presence of an open posterior capsule has been challenging, though we have managed it without too much of drama in the few cases that we have needed to do it.
Yes, that was a food for thought. Thank you very much, Dr. Mathew.